Professor Benson and your team to come up, please. Thank you. So it's the last item on our agenda this evening, and we're going to hear about all of the public health priorities for the year. I know you've seen this report, but I'm guessing you would like to talk to some of those things before we ask lots of questions. But if you could give some introductions first as well, that would be really helpful, and then I will leave you to...
Wonderful. So good evening, everyone. It's a pleasure to be here. I'm Professor Kevin Fenton, and I'm the Director of Health and Wellbeing at Southwark. I'm going to begin by providing a little bit of an overview on what we've been doing in public health, and then I'm going to ask my colleagues Richard and Sigrid to speak to both the drugs and suicide as well as the sexual health programs. And we're looking forward to your questions this evening.
Thank you.
So, very briefly, I've been in the job as the Director of Health and Wellbeing in Southwark for 8 months now. I began in April of this year. And my title is specifically not the Director of Public Health, because the vision, I think, of Eleanor Kelly and the leader is to really embed the public health function in the Council in a new and exciting way, ensuring that we're not just focusing on some of the classic functions of public health, but really thinking about our relationship with the NHS, really thinking about health in all policies and creating that excitement across the Council for public health, health and well-being, and to really make progress on some of the big challenges that we have in Southwark, working with traditional and non-traditional partners. So the papers that we presented today really provided a highlight of some of the challenges that we face within the borough with health and well-being, but also some of the key accomplishments to date. It also highlights some of the strategic priorities that I've articulated for public health team, which I hope resonate with what I know that the Scrutiny Committee has been interested in terms of really looking at how we shape place through social regeneration to improve health, really beginning to think about the role of public health in improving health care as well as social care, thinking about how we continue to have a relentless focus on improving health and tackling inequalities, looking at some of the big health issues that we're grappling with in the borough, focusing on health in all policies and making health everyone's business. So really thinking about our partnerships with housing, with adult and children's social care, with the environment, with parks and leisure and culture. And then finally investing in our staff and ensuring that we're making public health one of the best places to train, as well as one of the best places to work. And in the paper I've also highlighted some of the core values which underpin our work in public health, which include addressing inequalities, developing effective partnerships, and ensuring that we're using data and evidence effectively. So these overarching priorities really are guiding how we share our story of what we're trying to achieve in the borough, but also gives a sense for partners and staff within the council about where our core areas of focus are and what we're hoping to achieve. So with that, we're really pleased that we have a chance to do a little bit of a depth and in-depth review with you on 3 key areas. I'll begin with suicide, and ask Sigrid just to give a highlight of just a few things that I think will stimulate the discussion this evening. Sexual health.
Oh, sexual health.
Yeah.
So I'm Sigrid Blackman. I'm head of public health program for children, young people, and sexual health. So I'm going to take the report as read, but I'm just going to go through a few things. So the real headline at the moment is that levels of sexually transmitted infections remain high compared to other boroughs. Southwark has the 2nd highest rate of new STIs diagnosed. We had 8,100 new STIs diagnosed last year amongst our residents, and we also have the 2nd highest rate of HIV in England. With about 2,500 residents living with diagnosed HIV. And this is very much in line with our population being young, diverse, mobile. We have modern sexual health clinics locally, and our levels of STIs are broadly in line with our deprived areas of the borough. However, we do have some very good news stories within the last couple of years. We've had a decrease in newly diagnosed STIs, and that's been seen in Southwark and other parts of London and nationally. We had a 8.5% reduction in new STIs between 2015 and 2016. We've seen a 72% fall in teenage pregnancies since 1998, and we've had reductions in the abortion and repeat abortion rates. And perhaps most excitingly, we have had a reduction in new diagnoses and the prevalence of diagnosed HIV as well. Additionally, late diagnosis rate has gone down for HIV, but it remains at about 36%, so it's a key priority for us. you know, we have a mandatory responsibility to commission comprehensive open access sexual health and reproductive health services for our residents, and we commission those services in line with the principles set out in the Framework for Sexual Health Improvement in England. We commission a very broad range of services, from prevention to clinical services, online services, targeted services to at-risk groups. They're all listed in the report. I'm not going to go through them, but sort of the main area of spend is our 2 contracts with Guy's and St Thomas's Trust and King's College Hospital NHS Trust for GUM and reproductive health services. So as I said, we've made some enormous progress with sexual health improvement, but we have challenges that remain. The main one, I would say, is that demand for services is very much increasing in the face of continued budget reductions. We're doing everything we can to find lower cost and more efficient ways of providing sexual health services while ensuring that we're continuing to reach those most at risk so that we're not increasing inequalities. And the second one, which isn't really a challenge, it's quite exciting, but that's the PrEP impact trial. So we're very excited about that and the potential impact on HIV prevention in the future. So our local clinic at King's is now recruiting to the trial, and Guy's and St Thomas's is due to start soon. It's likely that there may be a small increase in clinic usage associated with the trial, and that could have knock-on effects for us cost-wise, but it remains an overall positive story, so we'll monitor that. And finally, at the moment, we are leading on the development of a new sexual and reproductive health strategy for Lambeth, Southwark and Lewisham, which will set out our shared vision for the 3 boroughs. At the moment, that's sort of summarised under 4 pillars, which is safe and healthy relationships, good reproductive health across the life course, high quality STI testing and treatment, and living well with HIV. So the strategy will review our current needs, evidence and emerging opportunities, and it will set out a framework of shared actions to improve sexual and reproductive health across the 3 boroughs, with that final draft due to be completed in February or March next year, and then ratified by various boards in the boroughs. So that was a whip through on sexual health. Thank you.
It would be worthwhile for Richard to give just a brief introduction to our work on suicide and drugs and alcohol, and then we'd be really happy to hear your questions.
So suicide is something that may have touched people in the room, and certainly it's one of those big events that you always recall. Fortunately, suicide is comparatively rare in the number of cases that we have in Southwark, and we have about 25 to about 30 cases per year. But we're not doing terribly well on this, if we're being totally honest. The rate in Southwark is higher than the London and the national averages, and we're certainly a bit of an outlier when it comes to looking across the rest of the other 6 boroughs in South East London as to where we are. Now, we had a suicide strategy back in 2005, and what we've spent the last 12 months doing is looking to refresh that. We set up a suicide prevention steering group, which is multi-agency, working with colleagues in the NHS, across the council, and through the voluntary sector and with organisations such as Samaritans. And that's been meeting over the course of the last 12 months. And what we will be presenting to the Health and Wellbeing Board on Thursday is an updated suicide strategy, which is in line with the Public Health England guidance, looking at a number of different elements of suicide prevention, whether it's through looking to reduce means of access, whether it's to seek to support people at greater risk. And we have a 2-year action plan associated with that. And we'll be looking to reassess that action plan at about the 18-month point to identify what other actions we can potentially take. Some of the challenges we have on this, in particular around data. Suicides, like I said, are fortunately comparatively rare, and that means that looking at the total numbers per year makes it very difficult for us to actually say it's gone down or it's gone up, because there's quite a lot of volatility. And so this means that we do need to look over a longer time frame, but also try and get better data. We're working with the local coroner to try and get to some level of almost real-time reporting, because at the moment we're 18 months behind the curve on all of this. And there's a number of other actions that we'll be presenting through the action plan to begin to address the gap on that. So I'm very happy to take further questions on suicide in a minute, because I suspect there will be some topics that come up. If I move very quickly to drugs, importantly I think for drugs, again, very vulnerable people in our community. Southwark it faces, like many inner London boroughs, the same challenges around drugs. For those of you who are thinking about your sort of associations in the popular media and with residents who potentially are affected by drugs, you may be thinking particularly about those using opiates, crack and injecting drug users. Of course, that means, well, that's a very sort of extreme end of the spectrum. And certainly we have historically treated those people, but what we're looking to do over the course of the next several years is to try and reshape our drugs offer to meet the emerging trends in drug misuse. And those include some of the things like novel psychoactive substances and other prescription drugs, for example, which are certainly causing various problems. Now, the bit that is really important, in particular for Southwark Council, is that from the public health budget we commission these services, and we currently commission CGL, which is our integrated adult treatment system, to actually provide a series of interventions, tiered interventions, to support people who have established drug and alcohol problems. So in the paper I've also included a few data on alcohol. We're working at the moment on an alcohol action plan, and we'll be hoping to take that through the Health and Wellbeing Board later on in the new year. So that's as much as I'm going to say on that at the moment, and I'm very happy to take questions.
Okay, everyone is furiously scribbling things down. I'm going to start with David, and then we'll look on this side. Come on, David.
Thank you, Chair. So my question on sexual health. So obviously, as you said, there is some good news in regards to what's going on in regards to STIs, and obviously particularly reduction in HIV. I suppose where I'd like some reassurance in regards to the figures, though, is firstly, I just wondered, so obviously I know from trying to use clinics myself that it's increasingly difficult to get a place for the clinic now. So I think now most clinics you have to be symptomatic to be seen. Otherwise you're obviously a home testing kit. If you ring Dean Street Clinic, which is one of the most popular clinics in London, their message says that they have 1,500 people chasing 300 appointments every day. So you have like a 1 in 5 chance of potentially getting an appointment. So I suppose one concern is that, have we got any figures yet to see whether the reduction in STDs is because less people are getting tested? And my second question, sort of related to that, is one of the reassurances we were given in regards to home testing kits was that SH24 had a very high return rate, I think something like about 80% originally. Is that figure still staying at 80%, or is it dropping? Because, for example, it's only anecdotal, but one of my good friends, he sent off for a home testing kit. He couldn't actually get enough blood out of his finger for the required amount. He needed a little vial of blood, and he just couldn't get it out. So he ended up not returning the whole kit. Unfortunately, it was just disposed of. So yeah, can you give me any reassurances on both those points?
Sure. So the point on access to clinics is a really important one, and it is a difficult situation that we're in across London. One of the things we're doing to combat that, as you said, is to develop online services as part of the London Sexual Health Transformation Programme, and we've led the way in having SH24, as you've said. We haven't had a decrease in testing. In fact, it's gone up over the years. We have one of the highest testing rates of our residents in the country. So I think we can give you some assurance, at least at a local Southwark level, that the decrease in STIs hasn't been due to
presumably your figures, if you don't mind saying, because the home testing has only really started to be bedded in the last 6 months or even less. So up until quite recently, you could still go into a clinic and even if you're asymptomatic. So I don't know, maybe it's too early, but I will take your reassurance.
It is something we're continuing to monitor.
Okay.
The most recent data we have is from 2016, so it's fairly recent. It shows at least a year of having SH24 in place.
And in
the second question was on the return rates of SH24. We monitor that on a monthly basis with our commissioners in Lambeth. They are still high. I believe they're above 80% at the moment.
That's good.
I don't have the most recent figures on me, but I can report them if you like.
I think with the return rates, we are, however, concerned that we're not seeing equal return rates across all demographic groups and characteristics. So I think there's more work that's being planned, especially at black and minority ethnic groups, and other groups that may not be participating in high return rates. But the fact that 80% or more are being returned is actually very encouraging, and that's been maintained. I also want to get back to the issue of capacity and access. This is a national issue as well, so it's not unique to what we're seeing in South East London. Again, nationally we know that attendances continue to increase, they haven't decreased, and we are seeing these consistent trends in reductions in STIs and really encouraging news about reductions in HIV in London. So there's something going on epidemiologically, which is good, at a time when there's significant pressure on clinics and clinic systems. So Public Health England's doing work on this, and we certainly will be doing work on it as well to be absolutely reassured that some of the changes that we've put in place in Southwark are having the positive intended effect that they should.
Just one very quick one, if I may, just maybe for more comment. But so obviously PrEP appears to be having good results. But is there any evidence yet that there's a rise in other STDs as a result of people relying more on PrEP than condoms?
So it's still a bit too early. The NHS Public Health England PrEP implementation trial started last month, and clinics are being recruited predominantly in Greater London and in Manchester, Newcastle, so the major conurbations. But as you may be aware, of the last 18 months, there have been a number of community-driven programs which have been encouraging men with sex offenders specifically to access PrEP privately. And we know that we have seen significant uptake of private prescriptions of PrEP. Those men are being seen in clinic for their routine monitoring far more frequently, and at that time they're being offered an STI screen. And there's some indication that actually what's happening is that we're picking up STIs among this very high risk group of men who sex with men, and that may be having a positive impact on reducing onward transmission of STIs. So the initial fears were that if men were taking PrEP, then that would be a sort of license for higher risk behaviours, lots of condom-less sex, may actually be balanced by the fact that men who are on PrEP are actually connected to services and are being screened more frequently, and that's having a positive effect. Again, it is too early to say, but we're monitoring the trends, and I think it's going to be really interesting, the patterns that we see here in England.
Helen, did I see you?
Oh yes, thank you. I had two questions, one on sexual health and one on drug and alcohol services. In the sexual health paper, it mentions a specialist young people's service, which is commencing, and I just wondered if you could give us a bit more information about that, given that obviously a lot of the issues around sexual health in terms of good practice and information, awareness, etc., we want to kind of instill those in our young people. And I know that there was also work done several years back, wasn't there, on a sexual health strategy in relation to young people, the teenage pregnancy work as well, and I was interested to know how that built on that previous strategy.
So we had an opportunity earlier this year in that our contracts for our specialist young people's sexual health service and our specialist young people's substance misuse service were both coming to an end. And looking at the evidence in that young people think about their health holistically, and recent reports into risk-taking behaviour, we decided to pull our budgets for substance misuse and sexual health and commission an integrated young people's wellbeing service that will also give sort of a holistic assessment of mental wellbeing as well, and we're working with other partners locally to develop additional aspects to the model, so potentially GP input, potentially additional mental health input as we go on. That contract starts on the 1st of December, so on Friday. We have awarded it to Brooke, which is a specialist young people's sexual health charity, and CGL, which provide drug and alcohol services and just happen to provide our adults service as well. So it will sort of be a soft launch initially. The contract does start on Friday, but we're working with them over the next few months to develop more of an outreach. They will have a hub in the borough, but more of an outreach focus. It takes time to develop these things.
I guess that's what I was going to ask, just like how do people access it? What does that look like? Is it a shop front? Is it kind of within other services?
So there will be a hub in Cambridge House where they can use that site for delivering interventions, so clinical interventions, group interventions. But there will be a significant number of outreach sites across the borough to settings where young people organically are.
I just want to say that this is a very exciting and innovative development for us in Southwark, and it's an area where, if proven to be successful, we will have a model that will be able to be taken up in other parts of the city. So we've seen some interesting trends in risk behaviours among young people. This generation of young people are drinking less binge drinking, they're smoking less, they're having less high-risk sexual behaviours. But we do know that among the most vulnerable young people who have these particular needs, and approaching it in this sort of whole child or whole youth approach is much more effective than developing individual services. And so that's the direction that we're moving in. Clearly for this generation of young people, increasing mental health issues is a big concern. So as we develop these integrated services, thinking about mental health is going to be a key part of that as well. So there's both good as well as bad.
Yeah,
next news.
Do you have a question on drugs as well?
Yes,
Yeah.
sorry. I feel like I'm taking a lot of time up. On drugs and alcohol, I was interested to know what waiting lists were like for residential treatment, because again I saw that it was being recommissioned at the moment, and I just was interested in the kind of demand for residential treatment and the extent to which we were meeting that as the borough.
We're fairly confident that we're meeting demand appropriately at the moment. The new commissioning arrangements are because of the expiration of the previous commissioning arrangements, and because we do need to continue to ensure that what we're getting is high quality and good value. The process through which we take, particularly the detoxification, which is the Tier 4 services, is that they are reviewed by a commission. It's then reviewed by a panel, including commissioners and clinicians, who then make a recommendation. And so there isn't really per se a waiting list, but there is a process through which we do assess need and make sure that they're appropriately directed to the correct service.
Sally?
Yeah, thank you, Chair. If I was listening or I heard what you said correctly, which is I think is common between the three of you in your presentation, suicide is very high in our borough. STD very high in our borough. Teenage pregnancy, drug and alcohol, and also combine that with mental health. Now, then, if you go to page 7, sorry, this is page 1. We have in our borough we have 20%. We have the 20% most deprived in England. In the last 20 years, we've spent. I think we've had about 3 different regeneration programs, and I believe regeneration is to transform communities and people within that community. Can you please tell me which communities significantly affected by all these issues, suicide, sexuality, STD, teenage pregnancy, drug, and so on? Because it's a similar question I asked at the last meeting. Can you tell me which communities mostly affected in this?
Sure. So the thing that binds all 3 of these issues is their concentration among the most social and economically deprived within the borough. And although Southwark is among the most deprived boroughs in London, we know that there's a lot of variation even within the borough itself. And there are particular wards, especially in the centre of the borough, which are more economically deprived and more socially disadvantaged. And where that is occurring, we have the clustering of both risk behaviours, so higher smoking, less physical activity, more mental health issues, and you have the consequence of those risk behaviours being concentrated as well. Therefore, you see higher levels of suicide, the higher STI rates, and of course, drug and alcohol. So any approach that we have in public health has to do 2 things. One, we have to ensure that we're providing universal services so that everyone can have access to high quality care and the prevention that they need. But we also have to target our interventions in the areas that are at greatest risk and which have the greatest burden of ill health. And that is why a big part of our work is using data to understand where to focus, and then working with the key community and clinical partners to ensure that we're also working in the neighbourhoods or the wards with greatest need as well. And we have some great examples of programs where we're doing that targeting in the areas of greatest need. Regeneration can help, because regeneration helps to change the physical environment, better parks, better schools, better health services, better opportunities for people to connect and to improve their well-being. but it's not going to be the answer. It's going to be certainly a part of the answer, and that's why we're focusing on social regeneration at the moment.
I think part of my question was which communities significantly affected by this, and you haven't touched on that. Because which community we have a breakdown of ethnicity of affected, so that we know how we can begin to tackle some of these problems.
Yeah.
So which community, ethnicity, could you give me some few examples?
So geographically, we're looking at some of the wards in the centre of the borough, which are more affected. Certainly, depending on the condition that we're looking at, we know that black and minority ethnic groups may be at higher risk. For example, for sexually transmitted infections, we sometimes see higher prevalence of HIV and STIs. For drugs and alcohol, we know that there's a concentration in the more deprived members of the community, and that is seen across racial and ethnic groups. So for each of these issues, we have slightly different patterns, but the thing that binds it together is, as I mentioned, some of the deprivation, especially in the more deprived parts of the borough. But I'll be able to provide you a bit more detail in some of the key populations for each of these, if that would be helpful.
Okay. Yeah, so my final question is this, Chair, on that. Will you agree with me that a cross-departmental strategy, since we all agree that, of course, very complex issue, but all these issues, whether it's STD, teenage pregnancy, is prevalent in a particular community or group of communities which are ethnic minority. Shouldn't then we be looking at a cross-departmental strategy? Because it seems that not one single department can deal with this, because they're so complex that you have to have a holistic approach to the problem. So shouldn't we be looking at that, and how far is your department having a dialogue with other departments in order to look at it holistically and how we can tackle the problem?
Thank you for that, and that's exactly what we're doing, and that's how we have a priority, which is around making health everyone's business, and essentially that is adopting a health in all policies approach in Southwark Council. So my public health team not just focuses on the mandated public health services, commissioning drugs and alcohol services or sexual health, but we are working very closely with other departments to ensure that health and well-being is a priority for them as well. So I'm very excited, for example, about the work that we're doing with the planning and regeneration team in the council on social regeneration, and that's a new strategic priority for the council. We're doing work with our housing colleagues on healthy, safe, warm, secure housing as a key driver for improving health. We're working with our colleagues in parks and leisure to look at how we use the green space across the borough to promote physical activity, mental well-being, etc. And it's these conversations and these partnerships which I think are going to be key for us having a greater impact as a public health team by not just focusing on the classic public health, but working across the council. So that's reflected in our business plan as well.
Thank you.
I had a question, which is, when we've talked about a number of these issues before, we've talked about the number of people who live in Southwark and access Southwark services, the number of people who don't live in Southwark and access Southwark services, and it would be useful to get an idea of kind of what all the figures in here, Southwark residents who access Southwark services, and actually are our services under more strain because we have larger numbers of people from outside Southwark accessing our services? I know that's particularly true for sexual health services because we've talked about that before, but is that true for some of our other services as well?
So for the sexual health figures, they're all Southwark residents accessing services across the country.
Oh, okay, right, okay.
That reflects the whole picture.
For substance misuse, the eligibility criteria are that you have to have essentially residence within Southwark. The only discrepancies that you do potentially get is that the way the health service works is on GP registered lists,
right,
but we work on residence.
Okay, that was my only question, just to check the figures. And Bill, I know you had a short question.
Yeah, just a really quick question. It was around TB and the fact that that's going up. If we don't have the data now, that's fine. We could have it later on. Would be good. And it was about why is that rising? Is it related to a particular ethnic group, or is it an influx of people, and where are they within the locality of the borough? Is it then, drilling further down, is there an adverse effect on the type of housing they're in? Is it our housing stock? Is it bad private housing stock? And it goes back to your opening line of everybody's health is everybody's business.
So I am concerned that the incidence of TB appears to be rising in Southwark, but we have some unique characteristics of the borough, which is probably driving it.
Right, that's what I'm after, I think.
And the key among those are the high amounts of in-migration that we have in the borough, from people who are coming from high prevalence countries. But we also have an established population of people who've migrated a long time ago and who are aging in the borough and who are now developing tuberculosis as their immune systems wane as they get older. There's also, given the ethnic makeup of our borough, we have population subgroups which generally have a higher prevalence of tuberculosis or latent TB anyway. So again, all of these things, the migration or demographic profile, the socio-economic profile of the borough puts us at high risk. And that's why we need to have both a strategic approach to addressing TB, which involves better screening for latent TB management. And your point about housing is an excellent one, because we know that poor housing conditions can be a risk factor for the activation of latent TB and transmission. So we're very much aware of this, and we're also aware that we're actually not, our trends are very different to the national trends, where we're seeing declines in TB in general in the UK.
Great, thank you.
Leah, and then I know Elizabeth's got a question as well.
Thanks. Given it's slightly outside of the three areas that have been focused on, I'm very interested to know some of the specifics about how the public health agenda is shaping place in the borough, particularly given the enormous scale of regeneration activities in Canada Water and Oldcombe Road in particular. I noticed in the social regeneration section of the public health plan various areas of focus, including health impacts along Oldcombe Road, the use of behavioural science methodologies to improve healthy choice architecture. I wonder if you could just elaborate a little on what that refers, what the broader scope of that, because there's sort of micro stuff and there's macro stuff in all of that. Obviously, there's big emphasis on parks, leisure facilities, but does it cover things like affordability, the urban form, permeability? How far does that go, and how much would you be influencing that area of action plan, which I understand is coming to Cabinet relatively soon? And just relatedly as well, in relation to your work with housing, to what extent that's looking at simple sort of warm, dry, safe, decent homes type indicators, and whether that's looking at things like active living and sociability in design, as well as security elements as well that are better covered in design guides that are used.
So I think this is one of the most exciting areas of development for the public health team, and we've been able to really build upon a long-standing program that existed on creating healthy places, but with the articulation of social regeneration as a cross-council priority, we now have a chance to take this to a new level. And there are three levels of ambition in which we're operating. The first is the sort of massive area regeneration, so Canada Water, the Old Kent Road area, to really ensure that we're embedding health and well-being as part of the regeneration efforts there, and ensuring that well-being is a core priority for those regeneration efforts. So we're developing a healthy Old Kent Road plan. We're holding workshops on a health plan for the Canada Water development. We've been doing some exciting work in Elephant Park in terms of health and well-being as a result of that regeneration. So not just for communities moving into the area, but for established communities as well. There's a second level of work that we're doing on healthy places, which is around maximising health promoting opportunities in neighbourhoods which are being developed. So Peckham, for example, the work in Peckham, the work in the Walworth Road area, other smaller developments which are occurring, and ensuring that we're working with those to look at education, facilitated regeneration schools, general practices, thinking about community assets which are there and how we use regeneration to help. And then at a more micro level, we are doing work on creating healthy high streets. So how do we work on, the chicken shops to ensure that they're doing better in terms of providing healthier meals? How are we designing on the high streets more health-promoting spaces and thinking about the balance between, for example, gambling or pound shops, alcohol shops on the high street? So there are things that we can do to design there, and our health teams involved there. So those are the 3 areas in which we're involved at the moment.
I feel like I'd have 3 follow-ups to each of those areas. I'm not going to go that far. I would be interested just to, maybe not necessarily through the committee, but to get an update on particularly the Healthy High Streets and also the work about the Healthy Old Kent Road plan. There are many kind of fundamental decisions being made at this stage that I think will have very far-reaching long-term consequences. Certainly Healthy High Streets, and Sunny and I represent a ward that when we turned up had the second densest cluster of bet shops and payday lenders in the entire country. Through asset management and planning tweaks, we've managed to roll that back slightly, but huge prevalence of late night off licenses, hot food takeaways, and a real challenge to sort of get on top of some of those issues and try and intervene on it. So I'd be really interested to do a bit more on the Old Kent Road plan and the high streets as well. But,
great. No, that sounds good. And then finally, I'm going to go to Elizabeth. So I know you had a question on suicides.
Thank you very much.
If you could can you just introduce yourself, Elizabeth, for the purposes of the camera?
Thank you very much. My name is Elizabeth Rylance Watson, and I'm a Southwark resident, and speaking tonight really also on behalf of Steve Lancashire and Tom White with our continued interest and campaign on mental health. We come with the question to do with the timing of presentation of decisions, which I understand now that the mental health strategy will not be going to sub-cabinet until the 12th of December, so there isn't the urgency perhaps. But the questions are, number one, in relation to the suicide strategy, and therefore what is also in the mental health strategy, is the thought that the target for suicide prevention, which I understand comes from NHS England, is for, in our view, an unambitious target of 10% only, and that maybe we should aim for Southwark to have a target of being the lowest in London. And I was very interested when I saw your paper about the rise in the incidence of self-harm, so that bringing in that population, so I suppose we're saying please consider that, but also the suicide strategy and the mental health strategy, and then the big emerging document which I have seen on the South East London STP for mental health. It feels as though these two, we had suggested one strategy, that's not going to be possible, but to have the two documents with some kind of common forward and some kinds of interdependencies, so that the progress being made on the suicide strategy and the progress being made on the CCG strategy are really looked at together. So this is our question stroke request.
So thank you very much for the question. Just a point of information to begin with, the joint mental health and wellbeing strategy that you mentioned is a joint document between the council and the CCG, so it's not just the CCG. So let's take the 10% target. This was a very contentious part of the strategy development. There is one school of thought that says we should be aiming for zero suicide, and certainly Thrive London, which is one of the regional groups, is proposing a zero suicide approach. I was quite attracted to that to begin with, and when I was reading up on all of this, myself and actually quite a few, for some reason, the medics in the room were very drawn to the zero suicide approach. We, however, got quite strong representations back from a number of the voluntary organisations and other partners who actually said that could potentially be stigmatising. And what we did was we looked at the Independent Mental Health Task Force recommendation around the 10% reduction. We've been working very closely with the STP, and we then, as a steering group, which is multi-partner and does have representation from voluntary sector and organisations such as the Samaritans, we drew up a proposal that it would be a 10% or at least a 10% reduction. Now, I'm just going to update you then further, and I think it was your colleague, Mr. Lancashire, I think, who attended our consultation event on the 1st of November.
He did.
We heard the message loud and clear there that there is this reservation, and we've heard that also from councillors and from other colleagues that maybe we're not being ambitious enough. What we've sought to then do is we've said, well, okay, the vision is to reduce it as much as possible, and I really welcome the point that you made there around self-harm, and what's very important here is that suicide as a number is fortunately quite rare, but actually it's the kind of the iceberg around everything else.
Yeah.
So what we've said is that it's about reducing suicide and self-harm as much as possible. But the target is going to be the 10%, which we think is achievable. We had conversations with British Transport Police who've done a huge amount of work on this nationally, and actually I think the steering group was quite cheered yesterday afternoon because actually that does look quite achievable. So that's what our position is, and what we're taking to the Health and Wellbeing Board, just to reiterate that, is a vision to reduce it as much as possible, but with a target over the life of the strategy being 10%.
Wonderful. I think that's all of our questions. So thank you very much for
Thank
this
you.
evening. And that is the end of our meeting. I should just flag that